Our next speaker is going to be Dr. Mohammad Jahweed. He's coming to us from Malaysia. Dr. Jahweed is a neurosurgeon at the University of Malaya in Kuala Lumpur, Malaysia. It's interesting how I met Dr. Jahweed. I was actually on safari in Kenya, and the safari van that I was in broke down, and his safari van, the one he was in, came by and they said, "Hey, you guys need some help." And we started having a conversation, and it was like, "Hey, you're a neurosurgeon? I'm a neurosurgeon." And here we are, years later, still friends, still keeping in touch. Welcome, Dr. Jahweed.
Thank you, Vak. It's a pleasure to be with you, and after a long time. And it's a glad. I think something we have in common. Basically, originally I'm from Afghanistan, actually, and Kenya and Afghanistan have sharing some things. Basically, like what the panel right now they discuss. And whatever the discussion was there, I just came back from Afghanistan about 2 days ago. I spent like 2 weeks there, and the same thing, the same discussion, the same things. We have a lot of things in common we can share. But for today's talks, can you see my screen? My screen is showing on the screen. Is it visible? I share my screen.
Yes.
You can maximize it if you like.
I will maximize it. Yeah, I think it's a little bit nice.
As a slideshow. There you go.
Very good.
All right. So basically, I think yeah, we have do a lot of things in common between Afghanistan and Kenya. I did some volunteer work in Kenya and Tanzania, and as long as I did in Pakistan, Afghanistan. This is part of my patients to basically spread and help all the depraved words in terms of to help them out. But today, I think the topic given to me is to talk about the 5 ALA, a little bit of share of experience. This was we have done in the past about like 9-year experience of 5 ALA. I'm going to share with you a little bit of those experience along the way. If you have any question on the discussion, we'll have it. I'll basically a little bit of Malaysia. I'm practicing in Malaysia, originally from Afghanistan. I'm living here for the past 20 years. I'm a straight professor in universities, and as well, I'm teaching the medical students, and I will practicing as a neurosurgeon. Malaysia is like 14 million population, like Kenya, maybe Kenya's 45. And the capital of Malaysia is the Kuala Lumpur. Beautiful country, beautiful people. And I love living here. This was my hospitals. 2 of these hospitals I used to work. This is 2,000-bed hospitals, university hospitals called University of Malaya. It's very well advanced, equipped with all the recent facilities. And currently, I'm working in a bottom. It's called Hospital Sonebulu. It's one of the tertiary hospitals. So we have run a little bit of basically 5 ALA studies, and with the aim of the primary objective of this study was to look how much this basically illuminated or as a dye surgery will help to look for the extent of resection of the tumor. This was the primary goal, and the secondary was to determine the influence of surgery on post-operative recovery of the patient. Like we're looking for the Karnofsky performance score, like how much does it improve? If you look into the glioma itself, basically from the literature, if you're looking, the glioma is normally looking, it's aggressive. It's a very aggressive tumor, which mainly happening on the 16 or 60 or 50 decades of life. But what I've seen in my clinical practice, actually, the pattern changed for the past few years. I can see that more and more young patients coming. I have a patient with 25 or 30 years with a grade 3 GBM coming to the hospitals. If you're looking to the aggressiveness of the tumor itself, I mean, for a surgeon, I think it might be very challenging to deal with the GBM because you have got some ependymal infiltration, and what you see with the white light, basically, it will be really difficult to operate. So mortality of these patients, once you diagnose it, basically within 14 months and to 1.5 years, basically it's expected the patient will be die. So if you're looking, I mean, the aim of our was to give disease-free survival to these patients, and we want these patients to, because it's a palliative surgery, to giving survival rate, overall survival rate of this one, and the aim was to gross total resection. So if you're looking for most of literature, if you do radical resection of this tumor itself, from literature saying that basically it's improving the survival and as well as progression disease-free survival. Yeah, I'll just cross a little bit. In Malaysia, basically the censor of this one we have, it was one of the old data we have collected from our Malaysian sites. If you can see the malignant glioma per year, we already have like 260 cases. Like it's the majority of the cases of the brain tumor, the GBM was at the top, 36.6% of the tumor. What we have done basically from 2006, it was in our department of our neurosurgeries, from 2010, we're trying to establish and do studies. We have done like almost 130 patients we included in studies. It was 9 years retrospective cohort studies. We just collect all the data retrospectively and we analyze all of them. So out of this 130 patients we analyzed, so 41 of them is basically he fulfilled all the criteria with 5 ALA. On other hands, 38 we putting on other arms, like we have not giving the 5 ALA. So 20 patients on one arm, 18 patients on the other arms we excluded from this study. All right. The inclusion criteria for this cases, I'll go back. Mainly the patient was 18 and above because 5 ALA is not giving below 18 years of age, or those patients we suspected with malignant gliomas, so high-grade tumors. All of them basically included in study. In patient who had tumor with distinct link, if you see on an MRI, it was ring enhancement, good ring enhancement, and thick wall. And we feel this is basically, it is a high-grade tumor we include in study. Exclusion criteria was we exclude all this metastasis or more than one contrast areas, or those patients who have a pacemaker, cochlear implant, like they are contraindicated for MRI. They cannot go to MRI machine because possibility for those patients we need an MRI. They have been excluded from the study. The extent of resection, again, we divided into 2 groups. If more than 98% removal, this is called gross total resections. If we left behind like 10%, this is called nearly gross total resection. If more than 10% remain behind, it's almost a partial resection. So we divide this patient into 3 groups. So this is the same things. 41 patients we're giving 5 ALA, 38 we have not given the 5 ALA. So the 5 ALAs who's receiving the 5 ALAs, normally what we have done is this patient early in the mornings before the anesthesia, 3 to 5 hours early in the morning, we have given them 5 ALA as a solutions. Normally 1 vial of 1.5 gram of gliolines, we just dilute it in the 50 ml of drinking water and ask the patients to drink. And then we wrapped up the patients because we don't want to expose the patients to the light because it's very light sensitive. And after that, we push the patients to OT. 5 ALA, if you're looking to the history of Florence, basically it's not something new. It's being in a market from 1998, and the use of this technique is almost relatively new in Malaysia. But we have started this technique in 2010, while the US adopt the technique in 2017. In UK, adopt this technique in 2018. If you're looking, the FDA approved. I was in US actually in St. Louis with Prof. Salim. I think still it was new, and they approved on June 2017 the 5 ALA, and I think it's much more practice in the US nowadays. This is the how does it look like? The 5-ALA itself is coming in vial. I think it's expensive. It's very expensive, almost like $1,000. I think one vial of them we can give. But for us, I think the hospital we used as it was a government project, and 30 gram of 5-ALA itself is contain about 1.7 gram of 5-ALA. One vial of this one contained 1.5 and 1.5 gram of 5-ALA hydrochloric. So we will use this one early in the morning. So a little bit of go to the cellular level of 5-ALA. What the 5-ALA do and what 5-ALA is? Actually, it's a precursor of the heme. I mean, indigenously, everyone has a 5-ALA itself. We have. So while we want to a little bit exaggerate this 5-ALA, we want to get the active component of this ALA, which is coming from it's inside the cells. If you're looking inside the mitochondria itself, there's got two components. A precursor of the heme is the glycine plus succinyl-CoA. Both of them combined together, it's become 5-ALA. 5-ALA then, due to a lot of enzymatic changes coming to the cytoplasm, from cytoplasm again becoming. So the active form of the 5-ALAs basically inside the mitochondria is called protoferrin 1X or PPIX. This is the active form, which is coming under ferrichelatase. It's enzyme, which is normally it's very expressed in tumoral cases, and non-tumoral cases doesn't have that enzyme much, but tumoral cases have more. And this active enzyme is basically those BBBs, your blood-brain barrier, getting destroyed. This actively uptake by the cancer cells. So what's happening when we change the filter of the microscopes, and it's needed special microscopes. It will be on the thing. We're using Zeiss, Leica. They have filters. When we change the length wave of the microscopes to the blue, normally when it emits in heating to the excess PPXI heating, the wavelength change. The wavelength change from 400 to 600, and everything is looking like bright up. So this is how does it, the wavelength change from the smaller one to the bigger one. So that's why that area looking like very bright. So this is the whole idea of 5-ALA technique, and it's easily can be identified. The tumor easily can be identified. I mean, if you look into this tumor on naked eyes under white light, no one can basically identify where the tumor is. So while we change the filters, if you look in the filter itself, we see that easily you can see the tumor itself. And the sensitivity and specificity of this red areas is quite sensitive. We have sampled that, and when we send for histopathology, basically there's a lot of tumor cells sitting in this area. So it's make for life for surgeons easily. If you're looking to GBM itself, as a surgeons, we see only this area of the lesion itself. But indeed, I think the lesion itself has got a lot of roots, and it's a lot of infiltrations through the midlines going through. So for us, we don't know how much you're going to take. And the current situation with white lights, basically everything is looking yellow, everything is looking good. So we don't understand basically how much part we take and which part we take. On the other hand, if you're giving 5-ALA, the tumor itself, it's like bright up in front of your eyes, and it's make life very, very easy to resect the tumor. So as I mentioned, the processes we give, we dilute the 5-ALA into 15 ml of waters. We give to the patient early, and after that we wrap the patients because we don't want to get exposed to light and sunlight as well. And after that we transfer the patients to the OT, and we position the patients and we vote. So we give like 3 to 5 hours ahead of anesthesia induction. We give the 5-ALA to the patient. We have done volumetric tests. I'm using the Osiris. It's a very fantastic tool to use for the volumetric of the tumor pre-operatively and post-operatively, and after that we manage and we see how much we have taken out pre-operative and post-operatively, and after that we're putting in our database. So this was the pre-operative. So the result of this patients, we have got 41 with ALA and 38 with non-ALA. The result, it's show basically it was male, females. It was almost homogeneous. We got on both arms. And if you look into the distribution, 90 to 83 patients we have operated. If you're looking at the tumor itself, even those tumor was in Alicant area with 5-ALA, basically we have quite good amount of this patient we have taken the tumor out, because it's giving a roadmap how to go there and how to operate and how to take the tumor out. If you're looking to the Karnofsky score, we haven't got any patients to drop in their Karnofsky score. Like, before was 70 and after operation it becomes 60, but we haven't got improved either. In both arms. So one of the objective to see if their Karnofsky score improves. Some of the patient improve, but we don't have significant drop of the thing. So it was one of the advantage with 5-ALA. I think it's good to improve in Karnofsky score. In spite of the fact the p-value was not significant, but some of the patients they improve after the operation. With white lights, those patients we have not giving the 5-ALA. We haven't have total gross resections, because we don't know how much you take. If you see, we have near gross total resection, we have partial resection. On other hands, when we give the 5-ALA, a little bit slow, slacking down. Basically, we have almost 7 patients. We have total 98% of the tumor. We take it out. So it was adjunct, and it was, statistically significant. The p-value that the 5-ALA will help. If you look into the level of recurrence as well, those patients without 5-ALA, the recurrence rate was high. While those patients we're giving with 5-ALA, the recurrence rate was much more lower compared to without 5-ALA. If you hear, basically we have only 5 here, 15 recurrence rate. So it means confidently the surgeons with 5-ALA, you can go and take out the tumor. So that was a recurrence rate. So you find, and it was statistically also significant. I'll show you a little bit of, I'll run this video. It's one of operative, this is one of the patients, basically we had it, the patient is a frontal GBM. If you look in the tumor itself, and if you look into the white light, you cannot see anything. So while we change the filters to the blue, so those areas you can see on the screen, it's, this area is not a tumor. This is the tumors here. And sometimes you see below the patty, if you remove the patty, all of them look like this. So the tumors look from far away, It's looking like this is a normal brain, and this is a tumor's brain. So it's a really good map for you. A little bit, I'll run the things to run and operate quite safely and take out most of the tumor. We have samples all those tumors. If it's very rubby and it's very red color, and we send for histopathology. Actually, the histopathology also like showing that those areas was the more red, those areas the more cancer cell was accumulated on those areas. So as long as you see the red area and you not basically compromise the function, you just take it out. But sometimes if it's an Alicant area and you feel like you're going to harm the patient, so you have to stop, and that may need follow up with a chemo and radiotherapy. The same thing is this is another video. Same thing is the more the red, basically the more the tumor's part is there. So it's a fantastic tool, a little bit of expensive. If you see the yellow light, you cannot see anything. So if you change the light as well, it is it's a magnificent view, and you can take the tumor out on this. So this was our pre-operative. Those patients we operated, actually, if you're looking quite huge volume, but still we remain some areas because near the internal capsules, we have to a little bit not compromise. So remain there, but we haven't taken, but only in 7 patients, we have more than 98% of resections of those tumors. Same things. I think this papers, I think we published. So 5-LS, I mean, if you look into the thing, 5-LS is a really, it's helping us out to remove the tumor, and it's improving the progression-free survival and overall survival. The rationale for this study was based on assumption the maximum cytoreductive treatment of malignant gliomas benefit to the patient. There is a large erotic basically study has done that, which in this study showing that if you're taking the tumor, it have to be concomitant with the radiochemotherapy. And that's very true, actually. Recently, some of our patients came, if you're taking the tumor out, I think within 2 weeks' times, I think you have to send for chemoradiotherapy. Otherwise, if you're sitting at the top of the patient for a month, 1 or 2 months delayed, we have seen some of the patient, the tumor is getting bigger compared to what it was in the previous one. So I think this part, I emphasize on those. If you're doing any kind of this kind of surgery, I think this patient need chemoradiotherapy within 2 weeks' times to operate. Otherwise, you'll be in square number one. So I think for all those patients going for 5-ALA, I think most of the time, I think you have to do it MRI within 2 weeks of times. But sometimes, basically, if you're feeling the neuronavigations or ultrasound or intraoperative MRI, that's not the standard of gold, because neuronavigation itself, it's the brain shrivel happening. Ultrasound is operative dependent, or if you're looking intraoperative MRI, most of the center probably don't have that kind of facilities. So I think 5-ALA will be the cheapest one, which now alternative is coming, the sodium fluorescence. This is more cheaper. So that's the thing. So this is one of the slides of us. We take out, if you're taking the samples, in this one is looking blue. I mean, the cellularity is so much less. If you're looking like red, if you sample from here, basically you see how aggressive the tumors are. So it's quite, this procedure is quite, it's a specificity is almost like 89%, and sensitivity is 82%. It's a quite specific and sensitive. So I'll move on to the conclusions. Our data, basically based on this data, show that the 5-ALA is improving the outcome of the patient, is improving the overall survivals and disease-free survivals. And in some patients, we've shown that it's improving the Kanofsky score, but our sample was very small. It doesn't show the graph of survival, but if you're looking through to those patients, I think after operation, the patient need to go for chemoradiotherapy within 2 weeks' times. In some cases, we sit at the top of the patients because due to the volume of the patient, 2 or 3 months, the patient remain not going for chemotherapy. When we come back, the patient, when we MRI, repeat MRI, the initial tumor was bigger than compared what it was in the past. So 5-ALA for fluorescent imaging guided surgical and GBM surgery is highly sensitive and specific, and it's important, significant benefit to the patient in terms of improve of gross total resection. The role of early MRI in the prediction outcome after surgery is controversial. I think that was my last slide, and that's a little bit of presentation, because if you have any question, I think you can ask me. Back to you.
Thank you so much, Dr. Jahweed. Are there any questions from, do we have any questions from the audience?
Yes, thank you so much. That's a great presentation. Regarding glioblastoma, there are so many ways to approach it. There are so many discussions around extent of resection, and this seems to be a great tool to apply to that, especially the extent of resection. But there are 2 questions. One, first, does this apply to other tumors? Can this be used for other tumors, or is this exclusively chemically created for GBM? And then the second question is, have you found that this has increased the total amount of tissue you resect? In other words, are you resecting more tumor and obviously less normal tissue, but resecting more total tissue, or Under white light circumstances, do you find you resect less tissue because you're concerned about taking too much, say, eloquent brain or too much margin? Do you feel that it's increased the amount of total tissue resection or decreased it? So those are the questions that we have. Yeah, you're welcome. Thank you.
Thank you. That was a great question, actually. That's true. I mean, if you look into the history of Allah, I mean, it is coming from 1998, actually. 1988, the first times to use it, not only using in neurosurgery in the past, it's through the photodynamic of the tumor, they're using in GI surgery, of stomach surgery, breast surgery, they've been used. But 5-Allah, and in Europe, I think in 2007, it started from Germany. And subsequently, we get exposed to this thing in 2010. In 2017, US, and now basically in UK as well, they're using it. So in term of the tissue excision, if you look into the metabolite of this 5-Allah, it's a precursor of heme. All in our body also we have. I mean, we have the PPIX. We do have, but the normal tissue, they keep the balance. Once the tumoral cells, basically the BBB drop down, the tumoral cells will take that one and they exhibit more. So in terms of surgery, I think this is a roadmap. Those tumorous tissues that like not useful, I think they uptake the dye. While the normal cells, basically, they will not take, because due to chelase enzymes in normal cells, they have less exhibit and they not converted that one, so they not uptake. So I think we take less tissue. And in regards to your questions, basically all the tumors will uptake. In terms of low grade, basically their uptake of the dye is less compared to high grade. So mainly we can use this one for the grade 3 and grade 4. Grade 2 and 1, I think they will not that much uptake of the tumor. So that's how there's a difference.
Very good.
I'm not sure. Did I respond to the question?
No, you did respond to the question. It is fascinating that you can, it sounds like, take more tumor tissue, but less total tissue.
Yes.
And that's really the benefit.
That's right.
And while it can be used for grade 3 and grade 4 astrocytomas, it can't be used for the lower grade ones as effectively. What about tumors like metastasis?
Metastasis also, they will uptake, yeah, they will uptake metastasis, but metastasis basically, I think, is very well encapsulated and localized. I think we can map it up easily, we can take it out easily in comparisons to GBM. GBM is, the nature of GBM is, it's a challenge for the surgeons. It's got very infiltrative kind of nature. So the tumor itself, you see it here, but their infiltration is far away. So that's the challenge in comparison to metastasis.
Very good. It is a fascinating topic. We have one more minute if anybody else has any questions. Otherwise, we can move on to the next presentation. Thank you so much for that one. That is always a fascinating topic to discuss.